Hello, everyone, and thank you for coming. My name is Jane Taylor, and I'm one of the pediatric pulmonologists here at UPMC Children's Hospital of Pittsburgh. And I have the pleasure today of introducing Dr. Ignacio Tapia. And he is a guiding light in the pediatric pulmonology and sleep research world. He does work on obstructive sleep apnea and also health disparities in the pediatric population. He got his medical degree from the University of Concepcion in Concepcion, Chile. He then came to the Children's Hospital of Philadelphia. He got his pediatric pulmonology fellowship and sleep fellowship there, and then went on and got a master's in clinical and translational research at the University of Pennsylvania. He went on and was faculty there for many years, and they always like to say that it's always sunny in Philadelphia, but I have a sneaking suspicion that it actually is sunnier in Florida. So recently, he moved to the University of Miami, where he's the division chief in both pediatric pulmonology and sleep medicine. So he has his funding from both the NIH, the American Heart Association, the University of Pennsylvania, and the American Sleep Medicine Foundation. He also sits on several national committees with the American Thoracic Society, the NIH, and the American Academy of Sleep Medicine. So without further ado, Dr. Tapia, thank you for coming.
Thank you very much. Thank you very much for having me and for the nice introduction. So we're going to get started with the loudest struggles of the night. So Savannah told me that she needed a catchy title, and my title was very boring, was only pathophysiology of OSA, so I had to ask Google for help. And then Google told me they're silent struggles of the night. And then I realized they weren't silent at all. So it went into loud struggles of the night. And then I love Lady Gaga, so I had to put Born This Way there because I will explain that later during the talk. And as Jane said, this is my current funding right now for MPI or COPI. I have an R01 investigating health disparities in sleep disorder breathing, and R33, and two R33s that are clinical trials. If someone has a question about the R6133 mechanism, they can ask me because I know that more than I ever wanted to know about these intricacies. As one is to test the positive airway pressure for the treatment of obstructive sleep apnea syndrome in kids with Down syndrome. And the other one is a randomized controlled trial for home sleep apnea testing compared to in-lab polysomnography for the evaluation of OSA in children. So the objectives of the talk, we're going to discuss the balance between anatomy and function in the pathophysiology of obstructive sleep apnea. I will also explain respiratory afferent sensory processing measurements, and we'll analyze the impact of obstructive breathing on cerebral blood flow regulation. So as a background, obstructive sleep apnea is very frequent. It affects 1 to 5% of the pediatric population. It's a chronic disease, second to asthma in terms of the prevalence. It is characterized by the repeated episodes of upper airway collapse during sleep. So many times when families do ask me what's happening to my child during the episode of obstructive sleep apnea, I explain to them, and this is years in the making that I realized this is the most dramatic way to explain it. As I explain, imagine that you're sleeping comfortably and someone comes with a pillow to your face and shoves it there. What do you do? And then parents tell me, okay, I like struggle, I get scared, my heart races, whatever. Okay, exactly. All that happens repeatedly, night after night, year after year, and that's why it has consequences due to the transient hypoxemia, hypercapnia, increased respiratory effort against obstructive airways, sympathetic activation, and a lot of other things that actually can have deleterious effect long-term. Now, another question, and I have an ED colleague here that I do remember when I was at CHOP, people were calling from the ED saying, so-and-so is in the emergency department because the child has obstructive breathing, and they want to know, is there a risk of dying now, going home? So typically, no, it's very rare in children. In adults, it can happen due to the cardiac complications, because the good news is that airway patency is restored by dilation of the upper airway muscles. We all do have episodes of obstruction during the night. However, obstruction doesn't go on forever until you die. You get restored by what's called the upper airway dilation reflex. So you sense the obstruction, and then you're able to dilate your upper airway and compensate for the obstruction. When you're not able to compensate for this obstruction, then you have obstructive sleep apnea characterized by either frank obstructive apnea or hypopneas, which is the reduction in the in the flow or nasal pressure, but not complete obstruction. It's like someone is putting the pillow on your face, but actually without the pressure to choke you. So, and now we're going to talk about the balance between neuromuscular activation and structural narrowing. So for upper airway patency to happen, we need this balance between the anatomy and function. As I explained before, we do have upper airway dilation reflex, so our upper airway will dilate. Will dilate forever? No, because you have the structures, you have your neck, we're not like frogs, right? It cannot be dilating forever to overcome the obstruction, so will depend on that. And typically, when parents ask me, is this due, for example, to adenotonsillar hypertrophy? When it's the case, the answer is yes, partly, but we do not know whether that's the only thing. Actually, we do know some, because in fact, many children do have recurrence of obstructive sleep apnea after adenotonsillectomy, and also there are kids who have small tonsils and adenoids, and they do have symptoms, and also they do have severe obstructive sleep apnea. And studies have shown that the presence of adenotonsillar hypertrophy has a correlation with obstructive apnea-hypopnea index of only 0.5. So 50% of the correlation is explained by the anatomy, but not all. So when the balance shifted to structural narrowing, you have obstructive sleep apnea, and when you have very active reflexes and neuromuscular activation, you will have airway patency. So factors that can affect the structural narrowing, anatomical factors, are adenotonsillar hypertrophy, very common, also obesity, because when we gain weight, we have weight gain in places that we see, for example, typically the belly, legs, or other places, neck in the case of adults, but also there are fat depositions in the tongue and in the upper airway that we don't necessarily see, and they obstruct the airway. And also you can have a mechanical obstruction of any other cause, like tumors that are rare in children. However, kids with severe laryngomalacia, eventually they can have obstructive breathing due to that as well. And in terms of factors that can affect the neuromuscular activation, we have the intrinsic neuromotor tone, so it can be affected in kids who have, for example, cerebral palsy, or in kids who are hypotonic, like the kids with Down syndrome. Also, it's affected by the sleep stage, because we have different sleep stages through the night. Typically in conferences, people are on a sleep stage 1, so they're like lightly sleeping, but not full sleeping. And then when we go to deep sleep and then overall REM, in REM, we're paralyzed except for the eye movements and the diaphragm. And it's supposed to be a protection mechanism, so we will not reenact our dreams and flying through the walls as Batman or whatever Marvel hero may be trendy. So that's why obstructive sleep apnea happens more frequent during REM. Also, the use of drugs, for example, benzos, opioids, or alcohol can affect that. And if you or your significant other, for example, go out at night and you have a couple of drinks, you may hear them snoring, even if they don't snore at baseline, and they do snore, they may snore loudly and have OSA due to that. So it's something very dynamic, as we see there. Now, in order for the neuromuscular activation to happen, we need an afferent sensation, right? Afferent pathway and efferent pathway for the upper airway dilation to happen. You need to sense the obstruction, and then you need to act upon the obstruction. So how does that happen? First, we need to sense it. And here on the right-hand side of the slides, I have a very nice slide from Netter that explains all the innervation for the sensation of the upper airway that can be tested. So there's not only one nerve. However, in the world of adults, for example, where they have strokes, you can sort of not predict, but establish that someone will be at risk of developing OSA. They're not able to sense the obstruction anymore. And you have it there. And on the left-hand side, then you have the efferent pathway, which is mostly the genioglossus. There are a gazillion. I'm so happy ENT couldn't make it. There are a million other muscles involved, but the most studied, because it's easy to access, is the genioglossus, and that also has been studied in children and has been shown to be activated in normal controls when you are inducing obstruction in the lab. So all of the work of the efferent limb testing, meaning the dilation of the upper airway in children, was done by my mentor, Carol Marcus, which like next week will be 6 years since she left us. And she studied upper airway dynamics across the age spectrum. So how do you study upper airway dynamics? Carol was very adamant about defending that children, not small adults. There was a lot of literature at that time testing the efferent limb of the upper airway dilation reflex in adults, but nothing in children. So to study, you need to provoke an obstruction and measure what is the flow. So you provoke an obstruction in the lab, and that's what we as fellows used to do a lot during the night, not with pillows, but we use a modified CPAP machine that was able to produce negative pressure. So you apply an orofacial mask, you have a closed circuit, and you're applying negative pressure until you provoke an obstruction. And here we can see that in the x-axis on the both graphs, we're gonna look at the adult first. Hold on a second, I need to put my pointer here, yeah. There, okay, good. So here we have the negative pressure that is applied in the upper airway through the mask, right? And also we measure the flow. At some point, this flow will be zero. When it's a complete obstruction, right? We have the intersection here, the flow is zero. And we are able to calculate the slope of this curve and also what is the pressure that you need for this flow to be zero. And this is the critical closing pressure of the upper airway that is a physiological measure that is not as popular as FEV1 or anything like that because it's more involved to calculate. So what is the critical closing pressure of the upper airway is the negative pressure at which, or pressure, because some people, you could be surprised, adults have positive peak rates, that you don't have any flow, that your flow is zero. So she studied normal adults and realized that their peak rate was -8, for example. This is a sample. And then she studied children. And actually, she found out that children had a very resistive upper airway to collapse. The machine was impossible to collapse them. The machine goes down up to -25 centimeters of water. That is a very important number. And actually, if you see here, you will have to extrapolate because the device couldn't go any lower. And this child, which is a normal child, will have a peak rate maybe of -75 or something like that. So it's very difficult to collapse the upper airway of normal children. So the conclusion of her body of work was that children have a less collapsible upper airway than adults. And this is due to an increased neuromotor activation. How do we know that this is due to an increased neuromotor activation? Because there are two methods of measuring upper airway activation during sleep that both are very complicated and are inducing collapse in the upper airway. In one of them, which is the activated peak rate, you decrease the negative pressure little by little, like -2 centimeters until you get to the closing pressure of the upper airway, and then you provide like the sensation for the upper airway to dilate. So every time that you decrease little by little, I'm going to show you here. You see that this is the slope, is the line actually the computer does. But you see that the values are up and down. It's because when you're decreasing the pressure little by little, I have suddenly an increase in flow because the upper airway is activated and dilates. Then we go again a little bit down, and again the same thing happens. All the time is getting dilated. So this is measured the activated peak rate. Another way is to measure the hypotonic peak rate, and in that case, you go down -10, -15 centimeters of water all at once, and you don't provide warning that you are going to decrease the pressure, and in that case, you measure the hypotonic peak rate only, because we don't have the time to activate anything. Okay. So she concluded that children have less collapsible upper airway than adults to increase neuromotor activation. And unfortunately, this decreases with age. So all of us who are adults here, every birthday, remember that your upper airway may get more collapsible. So take care of that. And then I started working in research, and I wanted to study the afferent limb testing. So when you don't know anything, right, you are fearless. And I say, Carol, I really want to study what happens with the afferent limb testing. And she say, okay, it's sort of complicated, but you can do it. And I say, okay, let's do it. And I will tell you everything that happens. So there were some data in adults. So adults have studied that, and also Carol did some of the study in children as well, that when you make adults with OSA and without OSA controls breathe through a circuit with an inspiratory load resistance, so breathing against a resistance during wakefulness, that adults with OSA had decreased inspiratory load resistant perception. The perception is measured with a Likert scale, how difficult was it or not was it, and the group of adults with OSA thought that it wasn't difficult at all breathe through the resistance, because most likely they were used to breathe through that resistance, and there's more about that in the presentation. Also, they had decreased 2-point discrimination in the upper airway. 2-point discrimination is a method that also the neurologists use to test sensation in the extremities and in other places. And basically, you use a compass-like instrument with blunted points, and you randomly apply 1 point or 2 points, and you start to decrease the interprong distance until the person tells you that they feel only 1 prong. I will show you a little bit more about that. Also, they had decreased vibratory sensation threshold in the upper airway. And importantly, at the time that UVPP, uvulopalatoropharyngeoplasty, was very popular, like 20 years ago, maybe, a group in Sweden studied the biopsies of the adults having this surgery for OSA and compared it for adults having upper airway surgery for any other reason. We tried to do that in children for tonsillectomy, but it was like impossible to get through IRB and all sorts of things for the normal control. So that's part of my dreams, but you can fulfill my dream if you want to continue research. And they showed that actually the adults with OSA have sign of neurogenic damage on the muscle biopsies. So then they started with the theory of the progressive snorer's disease, similar to the people who work on the roads with the jackhammer, right? So imagine you're working in the road with the jackhammer, a high vibration and everything, and they have a neuropathy in the fingers when they do that work for a long time. And it's supposed to do due to the vibration, they don't feel sensation anymore, they have dilation of the upper airways. And this group in Sweden has that theory that in adults, at least, you start snoring and you progress until you have OSA because you are starting to having neurogenic damage. The big question that we have was, is this all due to, for example, a secondary vibrational damage? Is all due to years of snoring in adults? Or is it a primary neurologic disorder? Are kids born this way? Maybe they are born with a congenital, if you want, sensation deficit of the upper airway. Then when you have a load of the upper airway, either due to obesity, tumor, hypertrophy of tonsils or adenoids, you will go into have OSA. You can remove the obstruction with surgery. However, you will not cure what the perception that they have, and they can go into recurrence of OSA. So to do that, and for everybody, I hear that people are trainees on J1 visas. I want to tell you that I was on an H visa and I was not eligible for any NIH or important grant funding in many foundations. So this was the first grant that I got right after fellowship. It was the American Heart Association. It was a super long stretch because they do fund projects related to stroke. So I based my project on what I wrote that we're going to long-term prevent a stroke, and I got so here I am, because otherwise I don't have to stay at shop or I will be talking to you right now. So we recruited children with obstructive sleep apnea and controls and decided to test their upper airway sensation with psychophysical methods. Now, what are psychophysical methods? Implies that I do a physical stimulus, I provide a physical stimuli to the participants, and the participants tell me how they react to the stimuli. So it is not perfect. You have to do several repeated measures to make sure that they're telling you the truth. For example, in the 2-point discrimination, I have the picture here of the compass lag with the blunted points. Here we can make the interprong distance wider or narrower. When you make it wider and you apply the 2 points, pretty much everybody will be able to differentiate the 2 points. It arrives to a point when the interprong distance is very small and you're able to discriminate only 1 point. However, children may be tired, maybe they want to go home, maybe the parents force them to participate in the research and telling me whatever. So that's why we need to repeat it. It's not perfect. So we found out that in the controls have less had better two-point discrimination because they were able to perceive narrower interprong distance. So here we have the median, the interquartile range is the box, and 5th and 95th percentile are the whiskers. And this is compared to the kids with OSA on this side that they had impaired two-point discrimination. All was done at baseline. This was in the tongue. We also tested them in the palate. And we find that the difference was even more striking, and actually the interquartile range didn't even get to touch each other. So there were a significant difference there. So we concluded that impaired two-point discrimination threshold was impaired in children with obstructive sleep apnea in the tongue and the hard palate. And importantly, this was compared to age and BMI matched controls. So we matched them so to get away with obesity or other situations. And again, we didn't know, is this a primary sensory processing abnormality or is this a secondary abnormality? So we needed to get away with the psychophysical methods and go to objective measures where the participants, if you want, will or interest it did not affect the data. So, and that's how we started studying respiratory related evoked potentials. So what are respiratory related evoked potentials? Like any evoked potentials, in this case are respiratory, they're a measure of cerebral cortical activity that is elicited by breathing against a mechanical load. When you measure an evoked potential of whatever that is, auditory or visual, you need stimuli, and then you're able to measure the cortical response. In the case of breathing, the most potent stimulus is the occlusion of the upper airway. Then you will feel it. It's very short, it's 400 milliseconds, so it's not something that you're conscious that your upper airway is obstructing, but your brain will sense it. Or breathing through resistances, and you can buy these resistances. In my case, I bought them through Hans Rudolph. I don't know if they're in business, and they could do the resistance that you want, so we use different resistances. And then you measure the response in different areas of the brain that we use FC, CC, OC, so all central. And RRP during sleep had already been done. And it had shown here, we have the kids with obstructive sleep apnea in green, and in black, the controls. And we have seen that the controls had a greater peak with the occlusion during sleep compared to the kids with OSA. So the kids with OSA had a blunted afferent processing in response to airway occlusion during sleep. This was done at baseline only. So then we need to know, for this impaired sensory cortical processing, it was restricted to respiratory stimuli only or not. Because OSA, in fact, happens during sleep. That's why it's called obstructive sleep apnea and not obstructive wakefulness apnea. Kids, when they're awake, and it did happen at my previous institution, that, for example, they would come to the emergency department, they would be hospitalized because they were super severe, or from the lab, for example, they were desaturating to the 50s, hypoventilating, it was a disaster. We say, okay, we need to admit them so they can have emergent TNA. And then during the day, the floor would say, why did you admit this person? They're like bouncing down, because they're more hyperactive. They're bouncing down the floor, they're singing, they look like ready to go home. I say, wait until they fall asleep. And then it happens only during sleep. So it's very important that we know whatever is going on during the brain, does it affect our breathing or also something else? And also another important question is it reversible after successful treatment of OSA? We're sending many, many kids for adenotonsillectomy, and then are we doing them a favor? Are we curing something or not? And the other question that we had, is it limited to sleep only? What happened during wakefulness? So then we decided to do respiratory and auditory cortical processing in children with obstructive sleep apnea. And we did that first during sleep, and I will tell you the entire story. And we're very lucky to get actually not lucky, because we put a hard work we deserved to be published in the Blue Journal. And for that study, we hypothesized that children with obstructive sleep apnea would have abnormal respiratory related evoked potential during sleep. We sort of knew that, but also we wanted to study auditory cortical processing, and we hypothesized that that would be normal. So the abnormality would be related only to respiratory stimuli. And we also hypothesized that the persistence of abnormalities would be the same following surgery. So this is No joke of study is 2 nights for the participants and for the postdoc or the researcher or the fellow doing it, that the kids come to the lab. In the first night, we test the auditory evoked potentials. So for that, we have a scheme here. This is the participant room. This is the control room. In the control room, we have the PSG, and we have a computer that is producing the stimuli, because you need the stimuli to have an evoked potential. And the stimuli are the 2 types. One is a very monotonous noise like this. And every so often, randomly, is something super annoying like beep, but short, like 400 milliseconds, but still the texts don't like you because when you're doing that repeatedly. So we do that during N3 sleep. And why during N3 sleep? Because a deep sleep is very difficult for children to wake up. And actually, there is a body of research telling us that little children do not wake up with fire alarms. So that's very important because they should be maybe even louder. So the kids go to bed at the time with ear insert. That was before AirPods, so they had a cable. The auditory stimuli were applied 500 times by 15, 30 seconds interval through a computer, and there were 50 milliseconds, these tone beeps. And for the RREP, on the second night, the participant will come. There will also be an N3 sleep. Also in N3 sleep, you tend to have very few obstructive events, so that was good for the kids with OSA. They have to sleep with a full face mask, a CPAP mask that was modified and was attached to the system. There was a computerized system that had a valve to produce the occlusion. And this was also connected to a pneumotag that was connected to the PSG and had a pressure transducer. So we see the deflection that the obstruction produces. And we did 400 occlusions as interruption of inspiration. So the computer has to see where the inspiration is coming, obstruct for 400 milliseconds. And after that, all these trials had to be converted from the system that at the time we were using Rembrandt to EDF, and then use another software called Neuroscan. And little by little, actually before AI, we were scoring the studies. And we found out that auditory evoked potentials during sleep in children, as we predicted, they were normal. So here in the curve, we have on the x-axis the time. This is the red line when in 0 should be 0 when the stimuli were applied. And on the y-axis, we have the microvolts. For neurological convention, negative is up and positive is down. And the greater the peak, the better. So we found out that OSA at baseline, the continuous line, OSA after the treatment of OSA, what is the dashed line and the dotted line, the controls have pretty much the same peak. So OSAs and controls and OSA after treatment had similar auditory evoked potentials. However, when we tested the RREP during sleep in children, we found out that OSA at baseline, whether here, they were blunted compared to the controls that are the dashed line. The controls had 2 peaks that were really higher than the kids with OSA. And importantly, the kids with OSA didn't modify that much after the treatment of obstructive sleep apnea. I forgot to mention that the kids were tested 6 months ±2 after their surgery. So we concluded that the kids with OSA had normal auditory evoked potential. So that answered the first question. It was apparently limited what we can test because we cannot test every single little sensation during the night. It's very involved. But at least they had normal auditory evoked potential. They had blunted sleep respiratory evoked potentials and didn't have improvement after treatment. So again, is this an irreversible damage? Maybe because it's part of the progressive snoring disease. We catch, the adult colleagues catch the adults after they've been snoring 30 years or who knows how long, and nobody knew. Or maybe it takes longer to recover. You know, when you do clinical research, you are depending on the patient showing up and their schools, holidays, COVID, whatever can happen that get on the way of all that. So the question is, maybe they take a long time to recover. So ideally, for example, if we were able or had funding to test the kids every year, maybe we have known that. And also, is something congenital? Are they born this way? And the big question that I had at the time was whether the blunted RREP was limited to sleep. So then I decided to study then the respiratory cortical processing to inspiratory resistances during wakefulness in children with obstructive sleep apnea. And the question that I had at the time, and all of this was part of the grant of the American Heart Association, was that typically, we study kids with OSA during sleep, and we sort of know what happens. But then during wakefulness, you still have maybe, at the time I didn't know, but I'll show you later, increased resistance. Maybe you still are breathing against an airway. You still have a large tonsils, adenoids, whatever that would be. So what we decided to do was to study the children using different type of resistances, 10, 20, and 30 centimeters of water, and occlusion as well during wakefulness. And this is also a very involved protocol where children need to come to the lab during the daytime. They need to be connected, as I want to show you here. This is my former co-fellow, Sofia Constantinopoulou, who's also a pediatric pulmonologist and sleep physician, and now works in Abu Dhabi. And if you guys do global in the Emirates, maybe you have met her, and if not, you should, so you can ask me her contact information. And she was our guinea pig for this. So as you see, Sofia is here with the electrodes that we need. She's using a modified CPAP mask that is connected to an pneumotach that we have here. Then we have to go through all these rigid tubes so we don't have issues with the flexibility of the tube, to the other room where we're watching her breathing. And in the other room, we have the computer with the different balloon occlusions that are programmed to see when you have the deflection, similar to what you see on the ventilator when someone's going to take a breath, and boom, you are occluding or applying the resistances randomly. And each of these resistances and occlusion were applied 100 times, so the entire test took 2 hours. It was a very funny research because we say, okay, we need to keep the kids engaged, we're gonna show them movies. So what does everybody say? Oh, let's show them a Disney movie. Okay, all good. And then what happened? They're singing along with the movie and messing up all the signals because you don't know what it is. And even the teenage boys that tell you, no, I don't watch that stuff. They are singing and la, 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 whatever with it wasn't like Little Mermaid or whatever was going on back then. So finally, we settled with the Diary of a Wimpy Kid that I have watched like a gazillion times. And it was perfect because there was no singing, but they were engaged and lasted the time. And I was, oh my God, the movie is going to end. We need to finish it. And we found out that in the RRP during wakefulness, the kids with OSA at baseline that continued to be the continuous black line had blunted peaks compared to the controls. After surgery, the peak still was the same. It didn't improve. However, the latency of the peak, the time that it took for them to mount the response, was shorter. So we concluded that, hold on, I have another one to show you. That was by occlusion, and this is one with the resistance of 30 centimeters of water per liter per second. We found the same. So we found out that they have delayed cortical neural activation elicited by airway loading and delayed latencies that improve after OSA. There also were tested like 6 months plus minus 2. So children with OSA have a reversible delay of respiratory afferent sensory processing during wakefulness. That's what we concluded. And we think, and that's a theory that needs to be proven, that this could be maybe due to neuroplasticity secondary to better gas exchange improvement. Also could be due to the decrease of the background load because the tonsils or adenoids were removed. But anyway, it suggests plasticity of the respiratory sensory processing with changes in baseline load state. And also, it's something that we wanted to do because all of this was leading toward, do kids have the same progressive snore disease, even though we didn't have the biopsies and we don't have it yet. And what happened with their upper airway vibration perception? So data in adults had shown that adults had a decreased vibration perception. And you study that with a vibratron that I'm gonna show you immediately there. That is this little device that has vibration units that you can turn it up and actually start to vibrate or turn it down until it doesn't vibrate anymore. And to study this in the upper airway has to go through this mechanical arm. We're wearing like the miner's headlamp to see exactly what's going on. And you have to put it right between the soft and hard palate and do first to make sure that the kids understand trials, ascending and descending in the fingers, right finger and left finger to make sure that we have data because it's psychophysical. We're depending on them to tell us what they feel or not. So initially we start with 0 vibration, the kid put the finger there and little by little we're turning the knob and we say, okay, tell me when you feel the vibration. And we repeat that like 6 times to make sure that they're not like fooling around with us. And then you start with a high vibration. So the pole is vibrating. You put the finger there and you're decreasing the knob little by little until they don't feel the vibration anymore. In the upper airway, however, we did only ascending trials because the ascending trials in adults, there were data that it could induce nausea and vomiting. And first, I didn't want to get vomited on. And two, I want the kids to finish the trial. And if they're going to feel like that, they want to do it. So we tested the kids before and after surgery and two controls. And we found out that they didn't have differences in vibration threshold. This vibration threshold, by the way, one or the max person that had 2.2, they're not like normal values for it because it's not a test that everybody will go to a pulmonologist or ENT and say, oh, let me test your vibration threshold in the upper airway. However, I do think that our data in controls provides normal value for this. And importantly, the data available in adults were not able to feel anything until they were up to 10 of the vibration threshold. And statistically, because it was a negative study, so you need to justify more, the statistician came to the conclusion that we needed to study like 3,000 kids to show a little difference of 0.2. So basically, it was like normal. And then we wanted to know what happened with the kids that are obese, because some kids were obese and some kids were not obese. So we did a secondary analysis in OSA as a control, studying the obese and non-obese. And we found out that even though the values were still within normal, even though they're not normal values, there was a slight differences in the vibration perception in the OSA group that were obese controlled with the controls compared to the controls that were obese. However, in the non-obese, there was no difference. So we concluded, and despite the low number, we got good power. So we concluded that children with obstructive sleep apnea and controls have similar upper airway vibration threshold. However, obese children with obstructive sleep apnea had impaired upper airway vibration threshold compared to obese control, even though being within the normal limit. But if we were to follow those kids year after year, and that's why the importance of cohort studies, we may find something. Maybe they're born this way, and then the obesity doesn't help. And when this study was done, that was already like 10 years ago up to now, the prevalence of obesity or incidence have skyrocketed. So I would expect that this has gotten worse. So if you want to repeat the study, it would be great. So we concluded that an upper airway neuropathy was unlikely to be a major contributor to the pathogenesis of OSA in children, at least at that age. However, it is unknown if they can progress to that. So we cannot refute completely the theory of Dr. Friberg, which is the Swedish physician who came up with the primary snoring disease. And then we wanted also to study what happened with airway resistance, because with all these data, we were understanding that children were having at least some issues breathing with upper airway resistance. So for that, we brought children with obstructive sleep apnea and controls to the PFT lab to test the hypothesis whether children with obstructive sleep apnea had elevated upper airway resistance in general compared to control patients, and whether this would improve or not with the surgical treatment, which is adenotonsillectomy. So for that, the children came, typically when you measure airway resistance in the PFT lab, kids are wearing a nose clip and they have a mouthpiece, so it's a closed system, they're in the box, everything is closed, and you measure the resistance that way through occlusion. We wanted to measure it through natural breathing. Some kids had mouth breathing, some didn't have mouth breathing. So we decided to test it with a modified CPAP mask, that it was here, the same one that we're using at night. And then we put all the apparatus of the airway resistance through the mouthpiece of the mask. And then we instructed the kids to breathe as they wanted. So we were measuring upper and lower. And we found out that the kids with obstructive sleep apnea had a significant higher upper airway resistance compared to the controls. Here you have the same, the median, the box is the interquartile range, 5th and 95th percentile, and outliers. And then the kids who with obstructive sleep apnea who were treated with adenotonsillectomy were worked back to the lab, and we found out that actually after treatment, the measurements of upper airway resistance via the plethysmograph had also decreased. Importantly, pulmonary function testing were normal in the kids, and there were no differences between the two groups. So we concluded that children with obstructive sleep apnea had elevated airway resistance. This improves after treatment of OSA and is likely due to upper airway loading, secondary, in this case, to adenotransdural hypertrophy. And the hypothesis that I have, and I hope it gets tested, is whether this may contribute to the increased frequency of respiratory diseases in untreated kids with obstructive sleep apnea. And to that end, I have done studies using large data sets, so we're not testing the patients. And one of those was, actually we did 3 of those, but in 2, we studied kids with asthma and OSA using the Kids Inpatient database that were like, I don't know, 10 years of discharges across the United States, different region, and the kids who had in the digital diagnosis OSA and asthma and were admitted to the PICU had more use, and were admitted to the hospital, I'm sorry, had more use of non-invasive ventilation and invasive ventilation compared to those who didn't have obstructive sleep apnea. So that makes me wonder, because also the data using RRP in asthmatics, whether you're breathing all happy, used to breathe at a higher airway resistance, you don't perceive it well, and you go to full-blown status asthmaticus because you're not perceiving it, versus someone who is perceiving it. And also we did another one that using the Kids Inpatient database that we studied kids with Down syndrome and bronchiolitis admitted to the hospital, and those with obstructive sleep apnea had longer length of stay, it was more expensive to treatment, they had more use of invasive and non-invasive mechanical ventilation. So moving gears, after all this, another area of my interest was testing what happened with cerebral blood flow in kids with obstructive sleep apnea. And this is because it's not part of this talk, but they do have many neurobehavioral abnormalities, overall executive functioning, they have ADHD-like symptoms, and etc. However, no polysomnographic measure has been able to correlate with these bad outcomes. So one theory that I'm still exploring is whether this could be due to cerebral blood flow response. And we wanted initially to study hypercapnia and hypoxia. However, to study hypoxia overnight was very complicated because of the setup to buy the gas that provided the hypoxia and administered too long time. For some reason, we required a letter from the Department of Defense or something. So I was applying to a green card. I didn't think it was the best thing in my interest to get involved with defense at that time. So we only did a hypercapnia. And to do hypercapnia, a cerebral blood flow response to hypercapnia, we hypothesized that children with obstructive sleep apnea have blunted cerebral blood flow response during wakefulness compared to non-snoring and snoring age-matched control. And again, we decided to test during wakefulness because everything is testing during sleep. However, the kids are still awake half of the time, sometimes more because they have short sleep as well. They don't sleep as long. And we wanted to know what's going to happen with that. So we paired with the physics team at the University of Pennsylvania. They have developed the near-infrared spectroscopy technology, and kids came to the lab. They were using this probe who were measuring different things, and we perform a hypercapnic ventilatory response at the same time. A hypercapnic ventilatory response is a clinical test that is used to test the respiratory drive when you suspect hypoventilation. So kids come to, or adults come to the lab, they wear a nose clip, a mouthpiece attached to an pneumotag, and they breathe through an anesthesia mask that is filled with 7 milliliters per kilo of a mixture of 95% oxygen and 5% CO2. We do hyperoxia there because we want to test only one drive, which is hypercapnia and not hypoxia. And they were asked to breathe normally. At some point, we close the valve and they start to rebreathe, and the CO2 start to go up, up, and up. And for the hypercapnic ventilatory response, what is important is to measure the minute ventilation changes, and they have to, the minute ventilation has to increase with the hypercapnia. That's the normal physiological response. I have done it on myself. Actually, the techs did it on me like 1 million times, and it took me up to 80, so I can tell you all about it. What is that? With 80, honestly, you feel like, even I knew it was research and we're testing all that, I rip all the stuff like the kids. So physiology takes over. And this is the setup. So we will measure the different values, the saturation of oxygen in the tissue, the hemoglobin as well, the baseline blood flow, And then we did the optical measure. We monitored the blood flow all through the baseline up to the peak until the mouthpiece was up. We had very cooperative subjects, as you see here, that were very into research. And this is the setup. And we decided to study snorers, controls, and kids with obstructive sleep apnea. Because at that time, there were already some literature, that wasn't that long ago, about kids with snoring also have neurodevelopmental consequences. And now there are more literature to come. And actually, we just got accepted to publication, but it's not published yet. The results of the pediatric adenotonsillectomy trial for snoring, that is a randomized control trial that we did in kids with mild sleep disorder breathing with an obstructive apnea, hypopnea index less than 3, that were randomized to early adenotonsillectomy between 4 weeks of randomization or watchful waiting for a year. So stay tuned because that should be available in the next month. And the main outcomes are neurobehavioral. Okay. So we found out here, we have OSA, snorers and controls, and on the y-axis, we have the cerebral blood flow response. To study the cerebral blood flow response, you have to measure the relative change from baseline and divided that by the delta in tidal CO2, because it could be that your baseline in tidal CO2 was 38, totally normal, the next person is 42, totally normal, and one kid can go to 65 and the following can go to 60 only because either they started to cry or they opened their mouth or things like that. So we have to normalize with the delta in tidal CO2. And we found out that the snorers and controls had blunted response to cerebral blood flow compared to controls. So it's something that we have to continue exploring. So the conclusion was that in obstructive sleep disorder breathing, they have blunted cerebral blood flow responses to hypercapnia during wakefulness. So we concluded that even mild sleep disorder breathing may be associated with deficits in cerebrovascular response. Now, we finished studying right before I left Philly, another set of kids that we did during wakefulness and sleep, and we have to analyze the data, so there's more to follow with that. So for conclusions, if we talk about the pathophysiology of obstructive sleep apnea and all the loud struggles of the night, we have that, we know, in obstructive sleep apnea, we have decreased two-point discrimination in the upper airway, increased upper airway resistance, blunted cerebral blood flow responses to hypercapnia, unaffected at that age that our kids were around 10, unaffected upper airway vibration threshold. However, in the kids that were obese, there were a difference between controls and OSA, and blunted respiratory related evoked potentials, which is an objective measure of a respiratory afferent sensory processing during wakefulness and sleep. And this is without counting what I'm studying right now, where are all the other sociological factors that can affect this, such as race, socioeconomic status, the neighborhood where you live. Dr. Francisca knows well here, right? You can be exposed to some toxins or not toxins, to pollution, no pollution, and all that can affect how your adenoids grow or not grow. So there's a lot of more to do, and I hope to have stimulated you to continue this fascinating path. And I have to acknowledge overall Carol. You know, Carol was an amazing mentor. As I told you, well, I'm a foreign medical graduate. I didn't study in the US. I didn't have a green card. I wasn't a visa. So I did have nothing going on for me for her to think that I could do something. However, she treated everybody the same. And I do remember that the first time that we met, and I was typing like a sleep study report with 2 fingers because I didn't have classes of typing in high school. And she told me, oh, you really need to learn to type, to take classes. And I said, like, what's this lady talking? And she said, yeah. And I said, yeah, okay, whatever. And she said, yeah, you need to, because how are you going to write your grants? How are you going to write your papers? And I thought that, okay, whatever. But then in the back of my mind, you know, all those words get somewhere and tell you that you can do it. So don't dismiss anybody because they don't fit the bill. And I have the rest of the team that work with me in Philly, and now I hope to replicate things in Miami, and that's my email. You guys have questions, and thank you very much.